Okay, great. Well, thank you for your attention, and we'll move on to Research Row now, so we'll get our speakers to come up to the front. And our first speaker is Linda Marban from Capricor Therapeutics, and she'll be talking about CAP 1002. Oh, you're standing in for her?
Yes.
Okay, I'll let you introduce yourself.
Thank you.
Okay.
Hello, everybody. Obviously, I'm not Linda Marban. She couldn't be here today. And I'm not going to tell you that I'm going to try to fill her shoes because I'd look a little funny wearing heels. But here we go. I'm Mark Awadalla. I'm the head of clinical for Capricor, and here we will be presenting our 36-month long-term data for deramiocel. That is the name that has been proposed by the International Non-Proprietary Naming Committee for CAP 1002. This is a very riveting slide that talks about our forward-looking statements because we are a publicly traded company. I'm not sure anybody's interested, but if you are, here it is. Okay, so what is deramiocel? I've heard many people say, oh, this is that new stem cell that's out there. I just want to clarify that we are not a stem cell. We don't engraft like stem cells do. We are endogenous stromal cells obtained from human hearts, and we infuse those on a quarterly basis, so every 3 months, and these cells have multiple modalities. They have immunomodulatory properties, they have anti-inflammatory properties, they have anti-fibrotic properties, and we've seen some benefits with these cells. So the study started way back when. It was called HOPE-2, and that was a 1-year placebo-controlled trial that we've presented results on before. And after that trial, when we saw some very positive data from that trial, we decided to have an open label extension, and there was a gap of about a year between when the HOPE-2 trial ended and when the HOPE-2 OLE, the open label trial, began. And so this is data looking at 3 years of patients taking deramiocel every 3 months on this study, and the study is still ongoing. There were 13 patients that started. 1 patient did withdraw immediately after starting for personal reasons, and then 12 patients have been religiously coming in for their infusions to date. So start out with some real data here. So this is the trajectory of the skeletal muscle based on the performance of the upper limb. And this is 3 years of all patients on CAP 1002 or deramiocel. And you see the slope of the line continually kind of slowing down a little bit, right? So after 1 year, patients lost an average of about 1.7 points on the PUL. At 2 years, they lost an average about 1.2, and at 3 years, they lost an average of 1 point. So how does this relate, right? So we went out to Dr. Chet Villa and the fabulous people at Cincinnati Children's, and we said, hey, you have a big database of patients. Can you please provide us data to show what the natural progression of this disease is in a patient population that matches our age, right? And where they are kind of relative to where they started HOPE-2 OLE. And those patients had to have a long-term follow-up period of 2, 3, or 4 years. And in 32 patients, we see that decline in an external comparator standpoint, as you see in the, I don't know, you can make it out, the purple line here. And it shows essentially a difference of about 3.7%, right? Which is, when you compare them, are statistically significant. Well, what does that 3.7 point decline translate to? Well, it translates to a 47% slowing of disease. That means if you were not on CAP 1002, you would have a 47% increase in loss of function compared to patients that are on CAP-1002. And so when I told you that some of the properties of CAP-1002 or deramiocel are antifibrotic, we know that the heart is really affected by this devastating disease. So we were measuring many measurements regarding cardiac function. And so here we look at left ventricular ejection fraction. And in 2 years, we saw the median increase in patients on CAP-1002 increase about 1.9%. Okay? Well, how do we use that as a reference? Well, there's a renowned physician by the name of Dr. Jonathan Susslow from Vanderbilt University who recently published a paper last year looking at what, in a clinical trial setting, what would be an impact measurement to show success in a clinical trial setting. And he looked at many different cardiac measurements, and he said, in a nutshell, that left ventricular ejection fraction, systolic and diastolic volumes, late gadolinium enhancement, which is essentially looking at the fibrosis in the heart, and a couple others are really predictive measurements for all-cause mortality in DMD patients. And so within that paper, he measured many different cardiac measurements. And in the red show what those measurements were. In his paper, he looked at a 1-year change, DMD patients lost about 3% in left ventricular ejection fraction after 1 year. That is a median of 47 patients, I believe. The 2-year change was minus 5 points, 5 percentage points, and that was about in 37 patients. Now, comparatively, when you look at a 1.9% increase versus a 5% decrease, it becomes clinically meaningful. Now, the patients really didn't align that much because when he looked at it, his median left ventricular ejection fraction of his patients was about 57%. And the range of those starting ejection fractions was 49 to 60%. So we said, wait, let's try to kind of match the same patient populations. And in our patient population, we had 10 patients that had cardiac MRIs. 8 out of those 10 patients had starting ejection fractions above 45%. So we said, let's look at the subgroup of patients that was above 45%. And here you see that in those subgroup of patients where left ventricular ejection fraction started above 45%, the increase was a little more pronounced at 3.1%, and it was sustained at 3% later on. Similarly, cardiac results with end-systolic volumes, improvement is the decrease in end-systolic volumes. We decreased by 2.1 milliliters per meter squared at 24 months, and we sustained that at 2.4, while we show a 5 milliliter per meter squared increase in the published paper. In looking at patients that are similar with a greater than 45% in HOPE-2, it's a -6 and -5.1. Similarly, and I'm getting brushed off the stage here, but similarly, the same concept happens with end diastolic indexed volumes at -7 and -5.7, and then compared to the 45%, which is 11.7, and sustained at 36 months as well. The safety profile is so far looking very, very nicely. We have not had any treatment-related SAEs. Most of the adverse events are grade 1 and 2 that are related to CAP-1002 are mild to moderate or grade 1 and 2. We have not had any deaths on this study, and it continues to have a favorable profile. You know, deramiocel is potentially redefining, where we envision a combination therapy with any therapy that's out there. And as you know, everybody says time is muscle. So we believe that the earlier you start treatment with deramiocel, you are able to preserve both skeletal function and cardiac function over time. And with that, I'd like to thank all our patients, their caregivers, their families, our investigators, all the patients, all the physicians who treat them. You know, keep up the good work. PPMD, your unwavering support, and all of our investigators, thank you so much. And that's it. Sorry about that.
No, it's all good. Thank you so much, not Linda, for that wonderful overview. And our next speaker is Joanne Donovan from Edgewise Therapeutics, and she'll be talking about Edge 5506. Joanne.
Thank you. It's a pleasure to be here, and it's really an honor to be speaking with you today. I'm going to speak about our therapy formerly known as EDG 5506, now called Sevasemten. And what we're doing is developing a novel approach to treating both Becker and Duchenne muscular dystrophy. We are a public company, and so I have a forward-looking statement. I'm going to talk about things that may happen in the future. Most importantly, Sevasemten is an investigational agent and not approved in any territory. So this is an oral drug. It's taken once a day, and the intent here is to preserve and protect muscle in individuals living with Becker or Duchenne. The goal is really to protect the most susceptible muscle fibers. We call them the fast-twitch muscle fibers. And our goal is to look at, to develop a drug that can be used either alone or in combination with other therapeutic approaches. As you see, there's wonderful groundswell of different approaches that have come up over the years. So in dystrophinopathies, fast muscle fibers are disproportionately affected by contraction. When you lack dystrophin, when the muscle contracts, particularly excessively, then it can cause damage. So even everyday functions can cause damage in the absence of dystrophin. And that's because what dystrophin does is it isn't creating power. What it is connecting the muscle fibers to be able to spread mechanical stress, the stress that happens when you contract muscle, to be able to distribute that over the other muscle fibers. And when you lack dystrophin, the fast muscle fibers in particular, when they contract, they don't have the support of the other muscle fibers, so they get damaged. And that is shown here, and it is shown very nicely in this video of mouse muscle. It's a finger muscle from a mouse that you can actually visualize. And what you see on the left is in the MDX model, when the muscle contracts, there is a series of events. Calcium influxes into the muscle membrane becomes leaky and lets muscle proteins out, and ultimately the muscle gets damaged. You see these blebs showing up that are fragments of muscle fibers, basically. And on the right, with Sevasemten, the muscle is still contracting. Basically, you've taken the edge off the contraction. And what happens is that it contracts, but it doesn't get damaged. So you maintain function, but protect the muscle as well. So what we are doing in the clinic is a series of clinical trials. We started with the trial ARCH that I will show you some brief data on in adults with Becker muscular dystrophy. Same pathology, basically, the same damage that's happening. And we have 2-year data there. Then I spoke yesterday about the series of studies that we are doing in Becker muscular dystrophy. We've also have 2 enrolling studies in Duchenne muscular dystrophy, the LINK study and the FOX, and I'll show you the entry criteria later. One preliminary data that we have from the Becker study that causes us to be quite encouraged is that we saw the biomarkers of muscle damage, things like CK and other proteins, go down dramatically with sevasemten and stay down over a 2-year period. And even more importantly, what we saw, this is an open label study, 12 patients for 2 years, we would have expected that they would have lost 2.5 points in their North Star. That's the natural history. In early clinical trials, we often compare with natural history to be able to understand better how the drug works. And in 3 natural history studies, you saw at least that much decline in patients like this with Becker. And what we saw instead was that the muscle was protected, the function was preserved over 2 years, so they didn't lose function. And so that is encouraging towards Duchenne as well. So our current study, LYNX, is in boys with DMD between the ages of 4 and 9, ambulatory. The trial includes about 11 visits over now 2 years, 3-month placebo-controlled, followed by an open label. We intend to continue open label study after that. That includes boys that are treated with steroids, with exon-skipping therapies that are approved. It also included a cohort of boys that were not treated with steroids. We also, given the landscape right now, we've also initiated a study called FOX that is including boys aged 6 to 14 that were previously treated with gene therapy at least 2 years ago. That is actually fully enrolled at this point, and we will have more information to share. We're looking at biomarkers, we're looking at function, we're obviously looking at safety. That's the most important thing in this study, and it's to determine, these studies are really to determine the dose for a larger phase 3 study. Lastly, where am I going to go here? I just want to thank you all. We can be contacted. We have information on our website and on social media and around to answer any of your questions. But thank you so much for your listening.
Okay. Can you sit here?
I'm supposed to sit here?
Well, thank you so much, Joanne. Our next speaker is Maitea Guridi. She's going to come back and give us more information about Satralizumab. Thank you, Maitea.
So now is where I get to tell you all about our new clinical trial, which is called SHIELD DMD. So SHIELD DMD, it's a global clinical trial to test the safety and efficacy of a medicine called Satralizumab in people with Duchenne aged 8 to under 16. The interesting thing with Satralizumab is, I've told you right before, the potential that Satralizumab has to improve bone health, but because Satralizumab is also an anti-inflammatory molecule, we think it also has the potential to improve bone muscle function. So in SHIELD DMD, we're going to be measuring and testing the efficacy of Satralizumab to improve potentially both bone health and muscle function. It's going to be run in 4 different countries. We will be running the trial in Poland, Italy, Spain, and obviously in the United States. We have approximately 7 sites in these different states that you see there, and we're currently working very hard with the investigators to get their sites ready to start enrolling. We're hoping to enroll and recruit the first participant in SHIELD DMD by the end of this summer. And you might be wondering what Satralizumab is. So Satralizumab is an antibody. So antibodies are human proteins, right? So Satralizumab was an antibody designed from human proteins. It's an antibody that will bind and block what I talked to you about before, is the IL-6 or interleukin-6 receptor. Interleukin-6 is a protein involved in inflammation. And with Satralizumab, what we do is we block the signaling of this protein, IL-6, by blocking the IL-6 receptor. We do this by blocking the IL-6 receptors that are found in your blood, in circulation, and also the receptors that are found in the surface of the cells, of all different cells. It's administered by subcutaneous, or what is injections under the skin, every 4 weeks. And the next question you might have is, why do we want to block IL-6 signaling, this interleukin-6, into Duchenne? So as Leanne told you, we are all now aware, unfortunately with Duchenne, because the muscles get weaker, we know that the bones also get weaker. And when the bones get weaker, we see osteoporosis and fractures. And this is unfortunately made even worse because of the long-term use of corticosteroids. What we know of the involvement of IL-6 in all of this is that there's a lot of literature. So we've been working hard at this with research the science, and there is information out there that tells you that IL-6 can promote muscle atrophy, and IL-6 is also known to promote bone destruction or bone erosion. And what we think is happening in DMD, it's kind of depicted in this complicated picture, but we think that because of the ongoing muscle damage, because of the lack of dystrophin, we have all of these inflammatory processes, damage going on that increases the secretion of the production of IL-6. This IL-6, in turn, will continue piling up on the damage to the muscle because of its inflammatory, pro-inflammatory action. And this IL-6 will also go to other types of cells and other tissues, and one of them is going to be bone. And in the bone, we know that IL-6 will slowly kind of eat at the bone, so it will create this osteoporosis and the fragility fractures that unfortunately happen in people living with Duchenne. What we think we could achieve with Satralizumab, this is our hypothesis, this is our idea, what we think that Satralizumab could achieve is by blocking this hyperactive signal of IL-6, we might be able to reduce damage to the bones and reduce damage to the muscles. And another key thing you need to know about Satralizumab is that Satralizumab is already approved for another disease, which is called NMOSD. You do not need to know anything about NMOSD, but luckily we at Roche know a lot about NMOSD. And we have treated over 4,000 people already with NMOSD, including children. And we have seen that luckily for us, it has a very good safety profile. It's very well tolerated. And most of the common adverse reactions that we observe in people treated with Satralizumab include decreases in white blood cells, headache, joint pain, and the injection site reactions. And the way we want to study Satralizumab in Duchenne is through this new clinical trial, which is called SHIELD DMD. It's going to be a 2-year-long clinical trial. We plan to enroll approximately 50 participants with Duchenne that are both ambulatory and non-ambulatory, aged 8 to 15. And this is going to be an open-label study, which means there's no placebo. Every participant is going to receive Satralizumab for 2 years, and we're going to be measuring things like, obviously, your bone mineral density. So we're going to be doing a DEXA scan every 6 months to see potential changes in bone mineral density. We're also going to be doing a spinal X-ray. Leanne has told you all about the nasty vertebral fractures, so we're hoping to see if there's any changes in these vertebral fractures through an X-ray, and also we're going to be doing the North Star ambulatory assessment and the performance of the upper limb to measure potential changes in muscle function. So this is going to be done every 6 months. And lastly, key eligibility criteria to participate in our new clinical trial. So you must be at least 8 years of age and under 16. You must be taking daily oral corticosteroids for at least a year, and we're going to be enrolling participants in kind of 2 separate groups. They're not separate, which is going to enroll everybody, but we have 2 different types of populations. One is going to be the younger ambulatory participants that have not yet suffered from a fracture, and in the second group, we will recruit participants that are both ambulatory and non-ambulatory, aged 8 to 15, that have already suffered from a broken fracture. And lastly, I think it's very important to highlight that, unfortunately, if you have received gene therapy, vamorolone, givinostat, exon skippers, all of these therapies are going to be exclusionary. So they're prohibited at baseline, and they're not to be taken during the first year in the clinical trial. But we've heard the community, and we know the importance of starting to generate data on combination therapies. So if you participate in SHIELD DMD, you will receive Satralizumab, and we will allow participants to take gene therapy, exon skipping, givinostat, vamorolone, and anything under the sun that could help you during the second year of the trial so that we start generating that valuable data on combination therapies. And with this, I would just like to thank you all once again. I hope our example before told you and showed you how your participation, your collaboration is paramount for us to keep advancing in the science and coming up with these potential new therapies in clinical trials. And thank you all very much for your attention.
Thank you, Maitea. And our last speaker in this forum, before we open it up for your questions, is Tanja Taivassalo from the University of Florida, who will be speaking about Tadalfil.
Thank you. And thank you to PPMD for giving us this opportunity to talk to you about our upcoming study, which I will share with you in the next 6 minutes. So we're going to talk about the vascular impairments that contribute to the DMD pathophysiology. And this relates to an enzyme called neuronal nitric oxide synthase, which plays a really important role in vasodilation within skeletal muscle. So with a muscle contraction, nNOS is activated and increases synthesis of another compound called cGMP. And this is just important because it causes relaxation of smooth muscle cells within blood vessels, and that allows for muscle blood flow to increase. And this is really important because exercise or active muscle has a higher metabolic demand and therefore needs a greater delivery of oxygen and nutrients. So nNOS is localized or anchored to dystrophin. And so in the absence of dystrophin, there is this mislocalization of nNOS from the sarcolemma, and that results in this aberrant signaling, reduced cGMP, and a lower perfusion and muscle blood flow. And that is termed this functional ischemia. And that is believed to actually increase the risk for injury during muscle activity, as well as promote exertional fatigue. So Tadalfil is a very potent vasodilator. It's approved for other clinical conditions, and it acts to improve vasodilation by inhibiting a molecule called PDE5, and this just allows for a slower breakdown of cGMP. And Tadalfil has been used in DMD studies previously. This is just one example, looking at post-exercise muscle blood flow. So you can see the untreated boys, the column there, shows this blunted post-exercise muscle blood flow if you compare it to the healthy controls, and that just reflects this impaired nNOS signaling that we know occurs. But if you give the boys just one dose of Tadalfil, at one of two different strengths, you'll see this increase in muscle blood flow, again suggesting the potential of Tadalfil to restore blood flow in response to activity and exercise in DMD. However, enthusiasm for Tadalfil as a potential adjuvant therapy was dampened after this phase 3 trial in 2017, where boys were given or randomized to one of two different doses of Tadalfil or placebo. They were monitored for 48 weeks, and as you can see, there was no difference in their primary outcome measure, which was the 6-minute walk distance. But a somewhat overlooked result, if you look on the bottom, was the performance of the upper limb. And the boys that were given Tadalfil had a maintenance or an improvement in the PUL score relative to those on placebo. And so we believe there are a few reasons that account for this discrepancy in these results. One being patients had a variable disease severity. And it's been reported that there's a downregulation of PDE5, which is the drug target, with age, and that would render the drug ineffective. The second reason is important in that Tadalfil really only works when muscles are active. And so it's likely that many of these boys, particularly the older boys with greater disease severity, had insufficient use of their leg muscles, but did use or rely on their upper extremities on a daily basis much more. And we believe that plays a key role in accounting for this positive finding in the PUL. And so this idea of combining Tadalfil with regular physical activity was supported by a preclinical study done by my colleague Sean Forbes, where he took MDX mice and he trained them for 4 weeks on a treadmill. And you can see kind of in the middle of the group that trained with sildenafil, which is a similar type of vasodilator, had a much greater improvement in running performance than MDX mice that just trained alone or those that just took the drug. So building on this rationale and these results, we submitted and were fortunate to get funding for an R21 study through NIAMS. This is an exploratory clinical trial called the VASO-REX study to provide proof of concept that combination of Tadalfil with regular physical activity can impact and improve muscle pathophysiology in DMD. And so the inclusion criteria are listed there along with the study design. And an important point I want to make about the design is that we will first screen boys for responsiveness to 1 dose of Tadalfil. And if they are responsive, they are then randomized to Tadalfil or placebo while doing exercise training on a bicycle for 4 times a week for 6 months. And our hypothesis is that Tadalfil will optimize perfusion to skeletal muscle during activity as well as after activity. That'll help minimize exertional fatigue and post-exertional fatigue, and then potentiate any kind of training-induced adaptations that we might get from the cycle training and the regular physical activity. So how we're going to look at responsiveness, we're using a technique that's overseen by my colleague Sean Forbes called MRI BOLD, blood oxygen level dependent technique. It's an MRI-based technique where it's used to look at microvascular function within skeletal muscle. So if you look at the diagram of the control, you'll see this increase in BOLD signal intensity. And that just reflects an increase in blood flow and muscle perfusion relative to oxygen consumption after a muscle contraction. And then if you compare that to the DMD boy, you'll see that that response is severely blunted in DMD, again reflecting this impaired vascular function. So overall, in the healthy controls, we see about a 4% increase in this BOLD signal intensity after exercise, and it's about half in DMD boys. So we've actually used this MRI technique to collect some pilot data in 12 boys, ranging in age from 6 to 14, and all of these boys were given a dose of Tadalfil. And what you'll see here is the pre-dosing and the post-dosing BOLD signal intensity, which is higher after dosing. We saw this improvement in the majority of patients, but not in all patients. So there are 4 boys, the light blue circles, they had no response to Tadalfil. And that just emphasizes the need and importance of screening for the drug target before entering them into the 6-month intervention. And so if we look at the boys that did respond, we had about a doubling of the BOLD response, again, suggesting that Tadalfil is restoring this microvascular function. And I'll also just point out, we did have one patient who had received the Sarepta construct 6 months prior to testing. It's the orange or light yellow circle. And you'll see his BOLD response is impaired pre-dosing, but it also responds to 1 dose of Tadalfil. So our study is just open to enrollment, and I won't go through the details of the exercise other than to say that boys will either take daily Tadalfil or placebo while doing this cycle exercise training. So we've done a separate study looking at cycle exercise training using these exercise parameters, and we have shown safety and efficacy in a group of 6 boys, and we'll share that information at lunch today if you're interested. And the other important point is that we will be supervising and monitoring this exercise training. All of the boys will get this wonderful Riften adaptive tricycle, which allows the boys to either do their training, their cycling in the stationary mode while you're cooking dinner, for example, or take it out on the road and just enjoy a bike ride outside. And it's all heart rate monitored as well. So with that, this is one of our amazing participants that will be at the lunch symposium. I want to acknowledge my team, but first and foremost the patients and their families for their dedication and their enthusiasm to participate in really anything we ask, as well as to the funding agencies, to Riften and PPMD. Thank you.
Thank you so much, speakers. It's really wonderful to hear the development that's going on with these different therapies. We're open for questions now. Microphone.
Hi. That was a great presentation. I'm trying to get this thing to work. I have a question first for Tanja. On your study with Tadalfil, as you know, Ron Victor was looking at beetroot extract. And, I mean, unfortunately, Ron's passed, but he had found that there seemed to be this ability of the compound to have the spatiotemporal qualities that intact dystrophin and NOS have, so that you generate and release the NOS with muscle use because of the deoxygenation. So my question was, have you done any studies seeing if there's an additive effect using beetroot extract with the Tadalfil?
I couldn't hear your last word. Using
Beetroot extract with the Tadalfil, based on Ron's study. Right, based on Ron Victor's studies.
Yeah, great question. We have not done those studies, but we have thought of that as well as another, additive. But as you know, Tadalfil is pretty generic and easy and available. So we're starting with that again as proof of concept.
Yeah, because my point was that with the dissociated NOS, you're not really generating the NOS near the sarcomella, and it's just very transient in its activity. And so I was just wondering.
Yeah, there's actually another drug as well that we're interested in by Bayer that acts as a soluble guanylate cyclase stimulator that would probably be more effective, but getting that drug is challenging.
Okay. And then for Leanne, I just had a question about the vamorolone. With the adrenal suppression being so severe, what happens to the endogenous cortisol levels? And is there a possibility that those kids might be more susceptible to stress-induced problems?
Yeah, that's a great question. So you're right, vamorolone causes profound adrenal suppression, even more so than prednisone, and I'm talking about the 6 milligram per kilogram, but even 2 milligram per kilogram vamorolone suppresses the adrenals. And so it does raise the theoretical possibility that the children on vamorolone may be more susceptible to have overt adrenal insufficiency symptoms with more minimal triggers. The thing is, though, with the way we counsel people to address adrenal insufficiency, we take every trigger seriously no matter what you're on. So the strategy doesn't really change that much in that if you have a fever that's 38 or greater, or if you have vomiting, or if you're going for surgery, or if you're going under anesthesia, no matter what regimen you're on, you need steroid stress dosing. Where the strategy does differ on vamorolone is that you cannot stress dose with vamorolone. You can use prednisone and deflazacort to stress dose because they have something called mineralocorticoid activity, which keeps the sodium level up. And vamorolone is antagonistic to the mineralocorticoid receptor, which you know. But for the sake of the families, the implications of that are that we cannot stress dose with vamorolone. You can only use a classic steroids, and we recommend hydrocortisone. And that's why I say when you go and get your vamorolone prescription, you have to have hydrocortisone at the same time. We actually want you to have like a co-prescription so that this doesn't get neglected. So I'm really grateful for that question. Thank you.
Thank you.
Over here.
Yes, hi. First for Roche, can you talk about why the inclusion is only up to 16 years old, and are there any plans to expand that?
Does this work? Yeah. Thank you. So we were trying, this is the first time we're testing Satralizumab in the DMD population, and as a clinical trial, we're trying to maintain the population as homogeneous as possible. We've seen in literature, there's a lot of data out there, at least what that we found, with around bone health, bone mineral density, and we've learned this is usually reported in literature as much as 15 years of age. So we didn't, we felt a little, to be honest with you, uncertain of the older populations because we don't know that much about them. So we first want to have a look at this better known population, a more homogeneous population, to see if satralizumab has any efficacy and the safety as well. If this works and we do see a positive signal, we could potentially expand into all the populations for sure. We first just need to have an answer.
Sure, that makes sense. And if it gets approved, these all sound good, by the way, so thank you all for doing what you do. If it does get approved, would it be open to all ages, or is it too soon to say?
I would say it's probably soon, but this is what we're aiming for. We would fight and negotiate with regulators if, I mean, I don't know what Leanne thinks about this as well, but for us, there's no real reason why this type of molecule, this mode of mechanism of action wouldn't work in all DMD. We're just blocking IL-6. We're potentially improving muscle and bone. If it works in this population, we're hoping to expand and get access to all DMD if possible.
Okay, great. That sounds good. Thank you. And for Capricor, real quick, sorry if I missed this earlier. Are you still recruiting in any of your cohorts?
No, unfortunately not. We've completed all recruitment.
Okay. Thank you.
Thank you very much. Over here.
I'm Adele Abramowitz, and first I want to thank Joanne for that marvelous slide when you were talking about who you're recruiting, Duchenne and Becker's. You put a thought in my mind. I'm a manifesting carrier, and I'm here to promote. Wouldn't you consider a manifesting carrier more like, in a phenotype, more like a Becker's? Because we are producing dystrophin, and therefore when clinical trials are open to Becker patients, to include us carrier females.
Thank you.
Should be okay.
Is it? Hello? No, it's not on. Thank you for the question. The mechanism should extend to manifesting carriers, absolutely. One of the struggles in clinical trials is to be able to interpret the results and to interpret them in light of natural history. So that's why in Becker we do have, there's not extensive natural history, but there's at least 3 or 4 trials that do give us information on what to expect, and not only what to expect in comparison to open label, to people getting drug without a placebo, but also in terms of just planning trials, what group. So that's the difficulty, that we are not right now going into manifesting carriers, but the mechanism should be the same.
Yeah, I just want to, like I said, I just had a brainstorm, and it's a way of hopefully including us. Mm-hmm. And so, thank you.
Thank you. Over here.
Yes, thank you. My question is regarding Capricor and the recent really positive data. It looks promising, and I was just wondering, timeline-wise, in terms of looking for FDA approval, what that might look like, if you have any idea.
So that is the million-dollar question. Our goal as an organization is to hopefully have FDA approval in 2025.
Thank you.
Over here.
Leanne, I actually have 2 questions, if that's okay, but I'll be quick. For Tanja, I'm curious about my understanding of the original trials of Tadalfil and Duchenne and Becker is that there were real potential differences in efficacy in those 2 groups. And just looking at your list of mutations in the cohort that you have, some of those patients would be expected to have low levels of dystrophin production just based on their mutation. I'm curious if you look at the responders versus non-responders in your preliminary study, do you see any correlation between response and likelihood of any low-level dystrophin? And then how do you think about that moving forward into the next trial?
Great point. No, this is hot off the press data, so we haven't had a chance to do those analyses yet, but we will do that.
And then another quick question. So really excited to see IL-6 signaling inhibitors in this space. I'm still a little bit confused about, as we think about this trial, what is the outcome that would actually show efficacy in this trial? And I wonder if you could clarify that a little bit.
thank you. We're also very excited to be in this space and blocking IL-6. As you said, there was, to be honest with you, while we were working on this, we actually thought, why hasn't anyone yet tried blocking IL-6 in DMD? Because there's quite a lot of data out there that it has potential. Our primary focus is going to be bone health. We think, and I can explain to you also, in another disease, rheumatoid arthritis, they block IL-6, they see improvements in bone mineral density. So this is what we want to test in DMD. Our primary focus is going to be bone mineral density, changes in the lumbar spine bone mineral density C-scores. So this is something we have seen from natural history. It's declining, it's progressively getting worse in DMD patients. So we're going to try and see if we see any stabilization or improvements in the lumbar spine bone mineral density C-scores by DEXA. And at the same time, also, as I was saying before, as secondary endpoints, we're going to be looking into the time to rise from the floor to detect changes in muscle function and the North Star Ambulatory Assessment and the performance of the upper limb. So it's a phase 2, I forgot to mention that, it's a phase 2 clinical trial. So we're trying to figure out as much as possible of the potential of this molecule in DMD and get some answers.
Great, last 2 questions over here.
Morning. My question is specifically for vamorolone. So I believe, like, when it comes to traditional steroids, there is literature to suggest that they have some immunosuppressant effect. And for example, if somebody is treated with gene therapy or exon skipping, it might be playing a role in protecting against, the body sort of like clearing out the transgene or exon skip protein, right? And as so for example, my boy was dosed with gene therapy, and as we now deliberate about switching from steroids to vamorolone, I was wondering if you have, like, when you did the study, did you sort of like look around those immune suppression markers, if you measured that as part of your trial?
Yeah, that's a great question. So you're asking about the role of vamorolone in the immunosuppressive landscape and whether it could be used in the gene therapy setting, for example. And I personally haven't seen any data that looks at immune suppression markers in the course of these trials. It doesn't mean that they don't exist, but I don't have that information for you. Maybe we can dig around and see what we can find for you. Over here.
Hello. A question for Capricor Therapeutics. Are you planning to open trial site as well in Europe? If yes, when are you planning to do it?
Yes. So actually, our European plans are currently underway. So we have to first speak with the rapporteur in Europe to kind of see if a clinical trial is needed or if the data that will be generated in our pivotal study will be accepted. So currently, right now, we are making our plans to begin discussions with the EMA.
Thanks.
Great. Well, thank you for a wonderful session, speakers, and for such an engaging and attentive audience. And with that, we'll give a big hand to the speakers and move on to the next sessions. Thank you so much.